In our time together here, we're going to go ahead and discuss health and wellness. We begin our conversation here about health and wellness with some definitions here. So let's see, let me change my colors. So the first definition we're going to talk about, the first word is menarche. The E is long. Basically, that is the onset of menstruation. The time frame it can happen is anywhere between 8 and 16 years old. I want you to think about the person who's living the life of an 8 to 16-year-old person. Somebody who's 8 years old is typically in the third grade. Somebody who's 16 is in high school. So that's a very wide range. Okay, our next definition here is something called amenorrhea, is and otherwise known as the absence of a menses. You can have primary and secondary amenorrhea. Primary amenorrhea is when the menses has not begun by the age of 16. Now, if you'll notice, that's the end of this window, right? So if somebody has not begun their period by the time they're 16 years old, we should figure out why. What's the reason? Okay. Secondary amenorrhea is when somebody has had their period established and then it stops. Typically, this halting of the established menses lasts longer than 3 months. There's different causes of secondary amenorrhea, a hypothalamic dysfunction, things like anorexia nervosa. That can cause someone's period to stop because the individual becomes too thin and they lose their menses at that point because they're low body fat. Also, pituitary dysfunction, some medications that you can take to treat a dysfunctional pituitary can cause secondary amenorrhea. Finally, the last definition is dysmenorrhea. Dysmenorrhea is simply, and not simply, that's not the right word. Dysmenorrhea is painful menstruation. Again, you can have primary and secondary. Primary dysmenorrhea is caused by increased production of prostaglandins. Well, you already know, because I've told you, prostaglandins cause uterine irritability. We've talked about that over the last few weeks. So if somebody is having too many prostaglandins, it can cause painful menstruation. That's primary dysmenorrhea. Secondary dysmenorrhea is people that are having complications and issues with the reproductive tract. Things like PID, pelvic inflammatory disease, endometriosis are things that we're talking about here. The research says that if somebody's experiencing these kinds of dysmenorrhea, primary and or secondary, but certainly more primary because that's because of the prostaglandins. The treatment is to limit the caffeine. I don't know what the limit is, and limit alcohol. Certainly taking NSAIDs as an anti-inflammatory will help with the pain, or putting somebody on birth control pills because of the hormones that are in there. It will help with the painful menstruation. This is a very busy slide, and I apologize for that, but it's easier to learn it, I think, learn these two concepts when they're side by side because there's lots of overlap, okay? So what I want you to recognize is symptomatically, these are all the same, okay? So let's go side by side. So let's talk about premenstrual syndrome first. It's experienced by a decent amount of individuals, okay? 20 to 40% of people experience this, as opposed to premenstrual dysphoric disorder. It's felt by less people, okay? It's a more serious form. It's a depressive disorder where straight up PMS is not. Okay, so to diagnose PMS, somebody needs to experience one of the three complaints that are on this list. To diagnose somebody with premenstrual dysphoric disorder, the person must experience at least 5 of these things in this list in 3 consecutive cycles, okay? So if you look at the lists are identical on both sides. What we're looking at here is to diagnose this more serious depressive disorder, you need to be more have more of the symptoms for longer periods of times. The best advice you can give your patients in doing this is keeping a journal. All right. When do they feel these symptoms? And that way they can look back over the past few months. It'll be more helpful to diagnose the disorder. Next, we're going to talk about family planning and contraception. So as far as our role as a nurse, what is our job here? Now, remember, nurses can have different licensures. You can have an advanced practice nurse, and think of a nurse practitioner. That's an advanced practice nurse. They can write prescriptions, okay? Your bedside nurses, which is the program that right now that you are in, that is not a nursing license that can write prescriptions. So we all need to make sure we practice within our own scope and our own nursing license here, okay? But overarching, we are responsible for assessing, right? We assess our patients' needs, their desire, and their preferences for contraception. The healthcare team, nurses and the provider, will discuss the risks and benefits, and there as well as if there's any alternative methods. The best evidence says that we should involve both sexual partners, okay, not just one person. We need to check our assumptions. Do not assume all of our clients are heterosexual. Do not assume that they all know how to use contraception, okay? Be culturally sensitive, of course, understanding the limitations of our patients and our people that we're teaching. Some birth control options require touching of the body, and some people really don't want to do this. So we want to make sure that we meet our patients where they're at so we can support them to the best of our ability. Some contraception cost has a cost to it. Even though if the patient has insurance, not all insurance will cover all kinds of contraception. So before we recommend or we give information maybe about a certain contraceptive, we want to make sure that they can afford it. So kind of have that conversation as well. Figure out what their limitations for their insurance is if they have insurance. Consider somebody's age for certain options, things like birth control pills for sure, because there's hormones in there. So we're going to get to all of that. Is the person's partner willing to cooperate or not? That's an important conversation to have. We're going to go over all of these kinds of contraception. Okay, so we're going to talk first about something called a topic of natural family planning. There's different things you can do within this. Again, you want to find out, it's important to us like any other education to figure out where your patient you're talking to is at. What do they know about the conversation? What are they willing to do? So let's talk about abstinence. So what abstinence is that we are abstaining from any kind of sexual intercourse at all. That's why it works. You can have primary abstinence or secondary abstinence. And just like it says there, primary abstinence is somebody who's never had sex before. Secondary abstinence is somebody who has had sex before, but is choosing now at this time in their lives to abstain. So that is secondary abstinence. There are advantages and disadvantages of both. The advantages is the most effective method of birth control because there's no sex happening. The disadvantages is that it requires self-control. Okay, so that's that one. Natural family planning, still talking about that. The next one we're going to talk about is something called the rhythm method, also called periodic abstinence or fertility awareness, all kinds of things that it's called. And basically, in a nutshell, what we're doing here is we're not having any kind of sexual activity happening during the fertile periods because we're trying to prevent a pregnancy. That's what we're talking about this week, right? Contraception. So this works as long as you have regular periods. That's certainly helpful. If the person has a 28-day cycle and they're really regular, this works a little bit better. If somebody doesn't have regular cycles, it can be a little trickier. So the education is people that want to use the rhythm method to prevent a pregnancy, they must track their menses and understand that there is a high risk of pregnancy with just using this method. The next conversation under natural family planning is the withdrawal method. This is the oldest method of contraception. Basically, it's what the definition of the withdrawal method is: the withdrawal of the penis from the vagina just prior to ejaculation. That's what it is. So the issue is it's one of the least reliable methods of contraception because what lots of people don't know is that the pre-ejaculate fluid can contain sperm sometimes. And so when somebody believes that they are withdrawing at the right time, they don't understand that piece of it. So that's how the pregnancy can happen, okay? There's no protection against any kind of STIs here, and there's a big chance of pregnancy. The next one we're going to talk about is something called basal body temperature. To do this, a person needs to understand that the right around the time that the person is ovulating, the temperature drops a little bit and then rises. So it's kind of just like a little bit of a check mark, right? It goes down and then comes back up. So once we understand that, this process requires people to be very diligent about tracking. What I mean by that is that every morning before the person gets out of bed, they need to reach over and they need to take their temperature, an oral temperature, before they get out of bed. All right, so they're going to open their eyes, grab their thermometer, put their thermometer under their tongue, and take their temperature, and they're going to start tracking it. And they're going to go every single day. They're looking for trends, right? When you're tracking things like that, you're looking for trends. What you need to look for is, again, when the temperature goes up, right? I told you it goes down and then goes up. So they need to understand that they can get pregnant through 3 consecutive days of temperature elevations. So it requires a commitment from the person being willing to do this every single day to establish trends in their body. What's more of a disadvantage here is that it can be a hassle, right, to track this every single morning. Our temperature can be influenced by many different things: stress, fatigue, and illness, warmth of the bed, is there a heated blanket, those kinds of things there. So there's definitely a risk of pregnancy here with that, and no protection against STIs. Something else that we can do under natural family planning is use an app. Okay, that you can go old school and use a calendar too. But either way, whether if you're going to use a calendar method, what you're doing is recording your fertile periods on a calendar. Whether it's an app, there's lots of apps you can use to do this, or if you want to have a paper and pencil, you can use a calendar that way too. All right. So what we're doing is recording our fertile periods, like I said. So ovulation occurs about 14 days before the onset of our next cycle. So when you're tracking these kinds of things, you're looking for trends. This is all about looking for trends. It takes patience to develop and see these trends, okay? So we need to educate our people that want to use this to prevent a pregnancy, that they need to accurately record the number of days in each cycle for at least 6 months. All right, using a calendar or a tracking app on our phone. 6 months. And it needs to be done accurately. Again, we're trying to establish trends. So it works the best if you can use what we just talked about there, was the basal body temperature. So use them kind of in conjunction. That's where they're going to get the most success if they do it together. There's no cost here. Apps usually are cheap if they're not free. It's just a matter of tracking and looking for trends. There is a big chance for pregnancy here with this one. So next we're going to talk another way you can use natural family planning to prevent a pregnancy is by assessing our cervical mucus. So a person is able to do this themselves. It's also called the ovulation method. All we're doing is understanding the body here. We need to understand that following ovulation, cervical mucus becomes thin and flexible, which allows for the sperm to pass and be viable and motile, right? So what happens is when we are, this needs to be done every morning or every day. Again, we're looking for trends. A lot of natural family planning is looking for trends. So it requires somebody to be committed to what choice that they make. What they're going to do is they're going to check their mucus production daily and document it. And I'm going to go over kind of how you do that. So what we're going to tell our patients to do is every day they need to touch their genital area. And again, we're not reaching inside the body. We're just touching the outside of the body, seeing if we can get a little bit of this mucus and documenting every day what it looks like. Is it thin? Is it thick? Okay. And this is an example here of somebody who's been documenting, and using adjectives to describe it is the best way to do it, because it will help the person when they're looking back to establish the trends. This day looked like this. And so it just is a little more helpful that way. This word here is pronounced spin-barcate. That's how you say that. And that's what you're seeing here. The ability to stretch the mucus between 2 fingers because it is thin, right? So that's what we're looking for there. So disadvantages here. Your patient needs to be okay touching their body. Now, some people aren't. So like I talked about earlier, we need to establish that early on. And if they're not comfortable touching their body, this might not be the best option for them. So we've already hopefully established that. We have to understand that the mucus, the appearance and the the texture of the mucus can be altered by different things. Semen can alter the mucus, blood, contraceptive foam, vaginal discharge, any kind of infections at all can alter that vaginal mucus and can give us inaccurate readings. So now we're going to go on to barrier methods. We're kind of over the natural family planning. Now we're going on to contraception conversations. So barrier methods, this is an example. These are things that are definitions of barrier methods there. Typically made of latex, silicone, and polyurethane. They're safe, and some of them offer protection against STIs. Not all of them, but some of them. Let's talk about the male condom first. This can be made of different things: latex, rubber, polyurethane, all kinds of different things. We need to go ahead and place a male condom on an erect penis and leaving room at the top. All right, so they come on a nice little roll and just rolled over an erect penis. It can be used with spermicidal gel because that will help decrease the effectiveness to prevention of getting somebody pregnant. All right. So the advantages of a male condom, it offers STI protection, which is lovely. It's readily available. They've been around a long time. The disadvantage of a male condom is that there's a high rate of noncompliance because the activity that is currently being engaged in needs to be paused long enough to get the condom on. A teachable moment here is this. We need to teach our people who are going to be using this as their contraception of choice to use only water-soluble lubricant with latex condoms, okay? Some people believe that just because something is slippery, it's a lubricant. And that maybe by definition is true. But when you're talking about using a lubricant on a latex condom, you want to make sure that it's only water-soluble lubricants because otherwise it can decrease the effectiveness of it. It can put holes in it, okay? Male condoms are used only once and then discarded. We don't reuse them. The next kind of condom I'm going to tell you about is a female condom. These are internal condoms because anatomically that's what they're going to be doing here. It's a vaginal sheath. It is, and there's a picture here because again, I'm just trying to help it be a little easier for you to understand. What you're going to want to go ahead and do is you're going to insert the closed end of the pouch into the vagina prior to intercourse and anchor it around the cervix. And anchor isn't a word that I love. Basically, what you're going to put this in and push it up until it hits the cervix. It doesn't attach to the cervix. To me, the word anchor means it's attached. Like an anchor in the ocean is that it's kind of attached to the ocean floor. This is not that way. You're going to put the condom in, and you're going to push it up until the small part, the small ring is right below your cervix, okay? And then the sheath or the shaft or the sides of the condom line the inside of the vagina itself, and the larger ring comes out around the labia. That's kind of how this works. It does offer STI protection, is readily available, just like the male condom. And again, with the same disadvantages as the male condom, you have to stop what you're doing to put this in to prevent the pregnancy from happening. Next, we're going to talk about a diaphragm here. So what a diaphragm is a dome-shaped cup. It's made of flexible silicone, and it fits like a small little hat over the cervix, okay? This one is both of your condoms are used once and thrown in the trash. A diaphragm is not that way. A diaphragm, the person goes and see their healthcare provider, and they get a prescription, and it gets filled. And then you use this, and then you wash it, and then use it again whenever you're ready to use it again. A couple of things about that. You want to make sure that you don't use an antibacterial soap because it can be kind of harsh sometimes on the material of the diaphragm. You can use a milder soap for that, okay? So it must be fitted by your doc. I already said that, a healthcare provider, and then replaced every 2 years and refitted if there's a change in weight or after a pregnancy, you want to refit it again, all right? And this came directly out of your book of when you can put it in and when you can take it out. Anytime you're going to put something inside a female body, you want to make sure that they've emptied their bladder first. Just again, because of anatomy, you want to make sure that that bladder is empty. If you use your diaphragm correctly 100% of the time, it's very effective. 94% effective is pretty good, okay? But it has to be used 100% of the time. But the reality is that even with the best intentions, none of us are perfect. So realistically speaking, it's about 83% effective. Okay. So the disadvantage is that if it requires a prescription, so you do have to have an appointment with with a healthcare provider to at least get it started. You have to put it in correctly for it to work. You have to it is a little bit inconvenient because you have to make sure it's in. You have to make sure it's in before you start things up. It is not recommended for clients who have a history of toxic shock syndrome because that can that's caused by bacteria and that can lead to other complications. Down here, these are the symptoms in case you were curious of somebody who has toxic shock syndrome. So next, we're going to talk about a cervical cap. So a cervical cap is made of silicone rubber and it fits around the base of the cervix. So it's kind of like a diaphragm. It just depends on what the person wants to use. A little bit smaller than a diaphragm as far as going in circles here. So what's written here is the effectiveness of this. So your nulliparous, it's 86% effective. But for your multiparas, it's 71% effective, okay? And again, this is how you put it in and when you take it out, and again, that comes directly out of your book. You replace this every couple of years, just like your diaphragm. This also you have to get an order from the healthcare provider, and it's reusable. All right, so after you're done using it and you leave it in place, whatever the literature says to do, you take it out. You wash it with a non-antibacterial soap, like a mild soap, and then let it dry, and then you can reuse it again. I'm only going to talk just a minute about the contraceptive sponge. Last time I checked the data, people weren't using these as much as they used to, and and a lot of people have pulled them off the shelves. But since it's here, I'm just going to really quick tell you this does not require a prescription. When you can find it, it's something you can buy at any place where you can buy your condoms. It's a soft polyurethane sponge. It fits over the cervix again like a little hat. It's one size fits all. This right here talks about how long you should leave it in, and it does not protect against STIs. So let's talk about birth control pills for a little bit here. We're going to first talk about the combination birth control pills, and then we're going to talk about with just one hormone in them first. So the singleton hormone birth control pill. So let's talk about the combination birth control pill first. It has both estrogen and progesterone in it, which is good, right? That's the hormones that are going to go ahead and this is how this medication works. So what's the action of a birth control pill? The action of the birth control pill is because of the hormones that are in it, it suppresses ovulation. It leaves us in an anovulatory state. That's how it works. That's how it prevents a pregnancy because there's no ovulation happening. If we take it correctly, there's no ovulation happening, so therefore we cannot get pregnant. Also, it also thickens the cervical mucus, which blocks the semen. And this is all because of the hormones, right? It also alters the lining of the uterus, the decidua right there, and that prevents the implantation. Remember, if you're thinking when somebody gets pregnant, the uterine lining is very thick and welcoming, and this is the direct opposite of that, all right? So that's the action of this medication. So what does that mean? So when you take a birth control pill, what the literature says to have it be the most effective, the person taking it needs to take it at the exact same time every day, because what that does is that keeps the therapeutic level of the medication in their system, and then it can do its job. So if we're trying to prevent a pregnancy here and keep the person not ovulating, if we take the birth control pill at the exact same time every day, it keeps a steady stream of medication in their body, and it will in fact prevent the ovulation. What you don't want to do is take it at 9 o'clock one day and 11 o'clock the next day and 4 o'clock the next day, because that's going to create these peaks and valleys of the medication in our system, and the chances of it working to the best of its ability is less. All right. It's kind of like pain management, right? If you know your patient is on pain medication every 4 hours, you don't want them to have these huge peaks and valleys when they're in tons and tons of pain and then no pain. It's harder to control their pain. So we want to keep them at a nice therapeutic level with their pain management. And so the same thing here. You want to keep them at a therapeutic level with the estrogen and the progesterone to prevent the ovulation. And if they take it at the exact same time every day, the chances are good that that's going to work. It does require a prescription to visit somebody with a license to give them a prescription. And most of the time, they're going to want to do a pap smear or a pelvic on the patient before they give them a prescription. We need to monitor for adverse effects, and they're listed here. Certainly, the adverse effects are more common the older the person is that takes them. So that's something we need to be aware of. If taken correctly, which is taking at the same time every day, it's very effective. It decreases the menstrual blood flow, and it provides a protection against certain cancers. So I want to kind of go back to this line here, decreases in menstrual blood flow. When you have both estrogen and progesterone in your medication you're taking, which is what we have here, the estrogen really kind of brings that menses down to where it's trackable. So for example, you take the birth control pill in the exact same time every day, and then for 3 weeks, you take the birth control pill the same time every day for 3 weeks. And then the fourth week, you don't take the medication. There's no hormones in there. And that's when the person's going to have their period. So when you have a combination birth control pill, which is again estrogen and progesterone, the estrogen will help the person start their period at the exact same day every single month. That estrogen really kind of helps to anchor that piece in there. The estrogen also really helps have the menstrual flow not be so heavy. Okay, so it makes that be consistent on a schedule, and it also makes the amount less. That's the estrogen in there. So the disadvantages here is that because there's no barrier, there does not protect against STIs. There's a risk of a thromboembolic effect, and then also be mindful that some antibiotics, not all, but some antibiotics will cause our birth control pill not to work. So we need to make sure that if we're taking a birth control pill to prevent a pregnancy and we're sick, we need to make sure that the prescription we're given is not going to make my birth control pill not effective. All right, this slide talks about what do you do if a person misses taking their pill? Because I just said you want to take it at the exact same time every day, but what if they forget? So this is kind of what you would counsel them on. At the bottom of the slide, I just put different pictures of different pill packs. And again, I just kind of talked about it. Now, so you can have pill packs that come in circles or squares. It doesn't matter. These are 28-day packs. You also can have packs that are 90-day supplies, or it just depends on what the patient needs. And that's a conversation with their healthcare provider. But here, let's just talk about one of these. Let's pick this one. So here, this says Sunday. So how this works is let's say the person is going to take their birth control pill at 9 o'clock in the morning every day. So they start on Sunday. They take it every single day for 1, 2, 3 weeks. Now we get down here. Here is where they're going to have their period. All right. And then they will have their period in this fourth week. And then the next Sunday, they start their new pill pack. And that's how that works. This right here is the progesterone-only birth control pill. Okay, remember the last one we just talked about, there were 2 different kinds of hormones, estrogen and progesterone. This one just has progesterone. So it depends on why your patient is taking it. What is the goal here? All right. It's the same action with less hormones. All right. Fewer side effects, again, because there's less hormones. However, with the estrogen not being in there to help control that person's bleeding, we don't have that piece there. So the bleeding, the person's period can be kind of erratic at times, and it can be heavy at times too. It is less effective at suppressing ovulation because there's less hormones, right? That would make sense to you. I already talked about the breakthrough vag bleeding you can have. And the biggest reason, well, it depends on the person. If the person just has had a baby recently and they decide they want to breastfeed their baby, but they want to be on a birth control pill, they're going to be on this birth control pill. The reason is because estrogen will drive the breast milk. So if they're breastfeeding and they want to do that still and prevent a pregnancy and take a birth control pill, they're going to be written a prescription for a progesterone-only birth control pill because it will not dry up the milk supply. The next thing we're going to be talking about is the emergency contraception. Okay, so sometimes in certain circles they call this the morning after pill, and well, that's kind of what this is, all right? So what happens is the education for this medication is you're going to take this within 72 hours after having unprotected sexual intercourse. And before taking this medication, the literature says to take an antiemetic, because how this works is you have high levels of estrogen and high levels of progesterone, and that's how it works. But we already know, because of our time together, when you have high levels of estrogen and high levels of progesterone, it can cause nausea and vomiting. So a side effect of this medication is nausea and vomiting. Also, if the person's period does not start within 21 days, they should follow up with their healthcare provider to make sure that they are not pregnant. This is not an abortive medication. This is not abort an established pregnancy. Again, this is, you take this after you've had unprotected sex, okay? We do not have a positive pregnancy test here. Anybody can buy this. It depends on where you go. Some places will have it behind the counter and some don't. So it just depends on the store you're buying it at. Some stores will have it next to the tampons and the pads and the condoms, and some won't. You as a person going to buy this does not need to have an age limit, does not need to have any kind of parental consent, and is not required to get counseling by anybody. It's over-the-counter medication. All right? And that's the emergency contraceptive pill. All right, so next we're going to talk about the transdermal contraceptive patch. Again, the nice thing about today is that it's all the same hormones here. There's nothing new I'm introducing to you guys. So once you learn what progesterone is, again, you should know. What estrogen is, you should know that too. It's the same action, same side effects. It's just a different way of giving it, right? You can take it by a pill. You can use creams. You can use it on a patch, and that's what this slide talks about. Just like any other topical medication, you put it on your skin and it's delivered at continuous levels throughout the day, or throughout the month anyway, into the subcutaneous tissue. You want to make sure you put this patch on a dry skin, okay? The education says where you can and cannot put it. You're going to put it on once a week, okay? And you're going to rotate sites. And then you do use it for 3 weeks. Your fourth week, don't put it on. Period happens in the fourth week. When the period is over at the beginning of the new week, you start again. That's how it works, okay? It maintains constant levels of hormones in the body to prevent a pregnancy. Same hormones that I just talked to you about. No protection against STIs. We don't want to put our patches on any kind of loose skin. And it's less effective with somebody who is heavier than 198 pounds. You can't add more medication to it. That's the idea behind that. So again, it's a conversation with your patient, and maybe this is or is not the right choice for them. Next, we're going to talk about injectable progestins. We're talking here about Depo-Provera. That's the medication here that I'm going to teach you about. It's a progesterone that's injected into the body about every 11 to 13 weeks. And again, this all is in your book, so it's okay. It's only progesterone. So go back to the progesterone-only birth control pill. The same side effects are there, okay? The breakthrough vag bleeding, the breast tenderness, those kinds of things. That's all going to be there because there's no estrogen here. It's only progesterone. So the education here is we're going to start our injections during the first 5 days of the menstrual cycle and repeat it every 11 to 13 weeks after. That's how that works. We want to make sure anytime you're taking in progesterones only, have enough calcium and vitamin D in our system to protect the bones. That's really helpful there. If you or your patient who you're counseling knows that they have a problem with taking medication every day, and that's okay. I mean, again, where's the patient starting from? If they do have a problem taking medications every day, they're going to forget or whatever. Maybe this will work for them, but they have to go in and get an injection. So it's best to present them with everything and then let them make their own decisions. This does not prevent lactation because we know it's a progesterone, so it does not do that. The biggest side effect when you have only progesterone is an increase in weight gain. You can have some depression, and I already talked about irregular vag bleeding. The thing here, the difference with birth control pills as opposed to here, birth control pills, if you stop taking them, as soon as your body kind of kicks back the ovulation, you start ovulating and you get pregnant. Here, because this is injectable every 11 to 13 weeks. If you get your injection and then decide the next week you want to get pregnant, you have to wait until it's out of your system. So there can be a delay there for that. So let's talk about the birth control ring. Before I get into all of the words that are on this screen, I want to stop and say most of us think about a ring on like your finger. It goes directly around your finger. Here, that's not what we're talking about. I want you to look at this picture. So here's the ring. I'm using air quotes. You can't see it. But the ring is this blue thing here. But it doesn't go around the cervix. What they're doing is they're collapsing it almost like a smile. And it lays in front of the cervix. And I just picture it looking like a smile. So again, even though I know most of us think of a ring, it's a circle. It's not the way this one works. Anywho, all right, so birth control ring. There's estrogen here, and you know what estrogen does. It prevents ovulation. It thickens the cervical mucus. The same thing that is with the birth control pills. The ones that are on the market currently are NuvaRing and Annovera. Those are the ones that are on the market right now. It is there. You do require a prescription for this medication, for this contraceptive device. Excuse me. It is highly effective at 93% effective. One ring lasts for a year. When you take it out, wash with a mild soap and water, just like you would your diaphragms, okay? Mild soap and water, no antibacterial soap. And this is how the education on how you use it. You put the ring in, leave it in for 3 weeks, pull it out for the 4th week, and that's when they have their period. At the end of that week, you put the ring back in, and the cycle continues, all right? Does not need to be fitted, but you do have to get a prescription to get it. Does not protect against STIs. Same adverse effects as oral birth control pills. Again, I've taught you about the hormones, which is very helpful. These are the risks of this medication. But again, it's the same thing because of the hormones. So now let's talk about the implantable progesterone. Right now on the market is something called Nexplanon. That's what's currently available. It looks like a little matchstick. There's progesterone. It's a hollow little stick, and see, it looks like this right here. And inside that hollow little stick is progesterone. So this is done in a healthcare provider's office. They will go in and they numb the area and they make a little tiny incision. And they're going to put this rod in and put a little Steri-Strip, and that's it. So it's very, very effective in preventing pregnancy. Again, it's only progesterone, so the side effects that go with that, with birth control pill I told you, and the medications there apply here. The only real education here is that if you have it in that one arm, maybe not using blood pressure cuffs on that arm, just because it might be a little sore. You can, but it might be a little bit uncomfortable. It provides effective contraception for up to 5 years. So that's good. If you know you don't want to get pregnant for 5 years, this might be a viable option for you. But if you're unsure, you might want to get pregnant in the coming year or so, this might not be make the most sense to use for that year. Here, these are the things that go with progesterone only and no protection against STIs here. So let's talk about an IUD. That stands for intrauterine device. It is a device that's inserted into the uterus by the healthcare provider and left in place for up to 3 to 10 years. And that's a big window, and I understand that, but it depends on what kind is put into the person. You can have hormonal IUDs and you can have non-hormonal IUDs. So let's talk about hormonal IUDs first. Hormonal IUDs, most oftentimes they're progesterone IUDs, and what they do is they thicken the cervical mucus. Now again, look at the action under the other medication, other things we've talked about. Look for the progesterone only, and that is the action there. There are 4 approved hormonal IUDs currently as of this moment, and they're listed there. And, how long that they're in is a little bit different. Okay? So there they are. Those are the 4 that are there. The non-hormonal IUD is, like I said, there's no hormones. It's typically a copper IUD. It's called a Paragard. And it creates a toxic and hostile environment for the sperm, and so there's no implantation that happens there. It can be used for up to 12 years. It's made of flexible plastic, not copper, even though there's copper in it, but the whole thing is not copper, contrary to popular belief here. It's wrapped in copper, just the ends of it there, and not recommended for people who with endometriosis who already have heavy periods. This might not be the right option for them. So when somebody goes and they want to have an IUD put in, you have a consult with the healthcare provider. You discuss your reproductive options with them, and if this is a viable decision, this is what you want to do. You'll sign consents. They'll write the prescription. The order will come. They'll have you come back in to see your healthcare provider when the person is on their period. The reason they do that is because when somebody's having their period, the cervix is dilated just a tiny, tiny bit, and it helps them get the IUD in place. Okay, and it looks it goes. It's an office visit, and some people say it hurts, and some people say it doesn't. It just depends on the person, and it's very effective in preventing pregnancy. I will say, if somebody does get pregnant when they have an IUD in place, they don't take the IUD out because pulling an IUD out can dislodge the pregnancy. So they keep the IUD in until the baby is delivered, and we want to make sure that the IUD comes out with the placenta, which it usually does. I haven't seen it very often. But when somebody gets pregnant with an IUD in place, this makes them a high risk pregnancy right out of the start there. So they're doing lots of ultrasounds because there's a risk of perforation and all kinds of things that can happen with that. So they become a high risk pregnancy if somebody does get pregnant with an IUD. But it does not happen very often at all. So the disadvantages of an IUD is that there can be a risk of pelvic inflammatory disease or an ectopic pregnancy. Sometimes it can come out vaginally, especially on your nulliparous patients. If they're having any kind of issues with their string, if they reach inside their body to make sure their string is still there, and they can't find it, they should follow up with their healthcare provider. If they think they're having any kind of infection, they need to follow up with their healthcare provider. No protection against STIs, and then some different things as opposed to hormonal versus a copper IUD. All right, so those are the things you can experience, and increased risk of bacterial vaginosis with any IUD there. So when don't we use an IUD? Somebody who has an IUD, we don't want to use an IUD if they have an active pelvic infection, any abnormal uterine bleeding. Let's figure out why we're having bleeding and then fix that situation. Severe uterine distortion or torsion. That means that the uterus is tipped. Sometimes it can be tipped so much, or not like midline anyway, that it can be really difficult to get the IUD in. And if they have an allergy to copper, we're not going to use a copper IUD. This is just an acronym, and just this will help us educate our patients. The acronym is PAINS. If the period is late, maybe they're pregnant. If they're having abdominal pain or pain with intercourse, let somebody know. That's unusual. If they're having, there's an increased risk of infection, like any kind of STI exposure, abnormal vaginal discharge, let somebody know. If they're not feeling well, fever and chills, or their string is missing. So this is when to let somebody know. Oopsie, very messy. So if they're experiencing any of these, let somebody know so they can be evaluated. The last couple slides here for our conversation about contraception is permanent sterilization. I'm going to talk about 3 different things that are permanent sterilization. First is transcervical sterilization. And there's pictures here you can look at. If you've never heard of it before, that's why I put the pictures there. For transcervical sterilization, what happens is they put a small, flexible, it looks kind of like a straw, like this. It's this right here. It's hollow inside. Okay, that goes through the cervix into the uterus, and then they place these flexible agents inside the fallopian tubes. Okay, and they cause irritation in the fallopian tubes, and that's how it works. All right. So there are 2 methods to do this, and I wrote them here. There's the Essure and the Adena. Okay. It's done, like I said, in the doctor's offices. It's very, very effective. After they put these little agents inside the fallopian tubes, they leave them there, and they get reevaluated 3 months after to make sure that the tubes are blocked, okay? Literature says that normal activities can resume the same day of the procedure. It's quick, no general anesthesia needed, and it works very well in preventing a pregnancy. It is not reversible. Just like all 3 of the different kinds of permanent sterilization, you have to come back and be evaluated as a post-op visit to make sure it's working before you are told that you are in fact sterile. So here, there's a delay in effectiveness for 3 months. And during those 3 months, use something else to prevent a pregnancy until you come back and they can verify that it is working. So let's talk about a tubal ligation, female sterilization, bilateral tubal ligation, and I have a picture here that'll kind of demonstrate what I'm talking about. So where they either sever or burn or somehow block the fallopian tubes, and it prevents their fertilization. Depends on the healthcare provider. Some of them will actually make this interruption like you're seeing here. Some of them will just clamp the tube so it's interrupted there. It just depends on the healthcare provider. It is permanent contraception. It is done immediately. It can be done immediately after childbirth, within 24 to 48 hours. That's going to depend on what hospital a person delivers at. Some hospitals do not allow procedures to be done like this, permanent sterilization, in their institution. And that's something that you can discuss, or the patient can discuss, with their healthcare provider. Sexual function is not affected. It is surgery with anesthesia. It is not reversible, does not protect against STIs, okay? So it is surgery. It does require someone to be put to sleep. It's not really done in the doctor's office at all. It's done in a surgical room. Its male counterpart is a vasectomy. Again, we're still ligating, but we're ligating at the vas deferens. We're not ligating at the fallopian tube. So we're having a separation or an interruption in that tube, and that's how it works. This actually is, the difference is that this is not major surgery, does not require general anesthesia. It is done in the healthcare provider's office on somebody who's trained to do it, okay? So the day of the procedure, they do this, and it's done in, 20 minutes or so. It's pretty fast. The teaching is that they need to use a different form of birth control. Now, the book says this, 6 to 36, which I think is a huge range. The healthcare provider will give instructions to the patient and say, have sex this many times, and then after this many times, bring me a sperm sample, and I will look under the microscope to make sure that there's no sperm inside the sample. And if there are no sperm there that they can see, they will say, yes, in fact, it has worked. You are infertile. And then that's how you know when there's no sperm in that sample, okay? So you have to follow up and make sure. So when they leave the doctor's office, they'll be instructed to have scrotal support. So wearing tight underwear is what they're kind of talking about there. And just kind of laying low for the day. Ice is very nice, off and on. That really is helpful. Reduces the swelling. And it can be reversed, but again, this came out of your book, but what we're going to talk about, this is permanent sterilization for the man. It is short, safe, and simple, and does not affect sexual function, and it does not protect against STIs. A very, very small conversation about therapeutic abortion, because we've talked about everything else. What I will tell you is that it's a medical procedure that ends a pregnancy. That's what it is, a therapeutic abortion. They are done in clinics, okay? Not done in the hospitals. They're done in a clinic that specializes in this kind of procedure. They take about 5 to 10 minutes. If it's done in the first trimester, it's very quick, 5 to 10 minutes. Done in the second trimester, then it becomes a D&E, which we're going to talk about down here, and that takes a little bit longer. If the person chooses not to go inside the clinic for their abortion, but they want to take medications to abort the pregnancy, that can take longer because you have to wait for the medications to absorb and to work. It's a conversation between the person doing the procedure and the person receiving the procedure to figure out what they want, okay? So first trimester therapeutic abortions typically are done using a suction vacuum aspiration. It empties the uterus that way. We typically will do this procedure up until about 14 to 16 weeks of pregnancy when everything is smaller and it's safer. Second trimester abortions are riskier and they're a little bit more involved. Second trimester abortions are called a D&E, dilation and evacuation. They typically will use some suction and they have to use medical tools because everything's a little bit bigger, and it's done into the second trimester there. Bleeding and cramping is common after either one of these. Now, remember, these are not done by the person's healthcare provider. They're done in clinics. So we want to give education that they must follow up with somebody after they get this done, okay? With their primary healthcare provider, their OBGYN, whoever their healthcare provider is. If they're Rh negative, they should be getting a shot of RhoGAM, okay? And that's therapeutic abortion. The very end of this conversation talks about personal wellness. All right, just a little bit, this is kind of a general conversation here. Everybody should be receiving annual physical exams regardless of gender, okay? Women should be getting their pap smears done about 21 years old or within 3 years of sexual activity. So it depends on what's happening first. If your patient is over 30, they can be screened every 5 years. And if they're testing for HPV is also done at that time. So it kind of depends on what's going on, okay? At that time of the physical, the healthcare provider will also do a clinical breast exam. Now, on men and women, they both should be getting this done. That should not be the only time a clinical breast exam is done. It should also be done every month by the person when they're at home as well, okay? Here, a little bit about mammograms. So it depends on the risk. If there's a risk of breast cancer in the person's family, they're now a high risk. If there's no risk of breast cancer in their family, they're a low risk. And this kind of talks about when they should be getting them. Make sure that people are up to date on their immunizations. We need to know our own body. Wherever we're doing our screenings for and our assessments for looking for lumps, how do you know if something is different if you've never felt that part of your body before? So breast self-examination, again, I do understand that the person here that we're talking about is a woman, but everybody should be doing breast exams because it doesn't matter if you're a man or a woman, you can get breast cancer, all right? But assuming it's a woman who has their periods, you want to pick the same time each month, typically not around your menses, okay, because your breasts tend to be a little bit more swollen at that time. So know your cycles and understand that piece. It's important that the person look at the breast in the mirror with their hands at their side, okay, and then raise the arms above the head and look under the breast tissue and look at the axilla as well. Use the pads of your fingers, not the tips of your fingers. Look for any kind of hard lumps or knobs or any kind of discharge, any kind of dimpling or swelling, and make sure that if somebody is a little bit larger chested, they lean forward and look at the underside of the breast too. So to round out our class here, before we get into personal wellness, we're going to talk about menopause. We've talked about reproduction. We've talked about childbirth and now we're talking about menopause. So what menopause is when there's no more follicles in the ovaries that are capable of ovulating, meaning there's no more eggs. Women are born with all of their eggs, okay? So when we hit a certain age, and the average age is 50 to 52 years old, people will reach menopause. That's the end of their reproductive years, all right? It's influenced by overall health and genetic factors. Women should look to their mothers, if their mothers are still alive, and they have that kind of relationship with them, or their grandmothers, to see when they went into menopause, because chances are good it's going to follow very close to that cycle. There is something called perimenopause. Perimenopause is the time before menopause that the person can experience the symptoms of menopause, but still be ovulating, okay? So you can still get pregnant when you're in this perimenopausal state. And that can last 2 to 8 years. So let's look at the timing here. So if the average age of menopause is 50 to 52, and somebody who does have perimenopause can last from 2 to 8 years before they get any kind of menopause symptoms, they could be dealing with all of these symptoms for years, okay? So not everybody experiences perimenopause, but it can happen. So what are the symptoms of menopause and perimenopause? Hot flashes, mood swings. So what's the underlying factor here? This is because there's a drop in the estrogen in the woman's body. And when the estrogen drops, that's what causes all of these situations. The hot flashes, the mood swings, you can have a decrease in libido, vaginal dryness, other sexual changes there. Skin changes, your skin becomes thin and wrinkled. You can have an issue with osteoporosis because, again, that estrogen is very low. You can have a risk of cardiac disease, stroke, and hypertension, all because your estrogen is low. So this is happening to everybody who has these parts, whether we like it or not. The best thing you can do is educate people, tell them what their options are, and let them make an informed decision. We're going to talk more about that in a second. So these are the things that you can do to help with the symptoms. Does somebody have to do these things? No. Some people go through the menopause situation and the years that it takes to go through that without needing any kind of medication at all. And some people do like to take some medication. So again, our job is to give them all the information that they need to make an informed decision. Risks, other things that they can do if they don't want to do meds, okay? You can take calcium. You can take selective estrogen receptor modules. These things are pretty much, they mirror estrogen, but it's not really an estrogen. And you can take just straight up estrogen. All right? Because again, what's happening is the estrogen is low. So the thinking is that if you can take supplemental estrogen, brings the estrogen up, and people experience less symptoms. All right? Which makes sense. Estrogen comes in all kinds of, it comes in pills and patches and creams and vaginal inserts, all kinds of ways. If your patient has not had a hysterectomy, meaning they still have their uterus, you must combine estrogen with progesterone. Otherwise, it'll increase their chances of having uterine cancer. Okay, so that's kind of one caveat with that. You can also take low-dose antidepressants, and you can take gabapentin, and you can take clonidine. So it's a conversation between the healthcare team and the patient, and let them decide if they want to take a medication. These are the things they can take. Finally, a bit about professional wellness. So this conversation might be new to some of you, and it may not be, and that's fine. A little bit before we get into it, I will say the best nurses are compassionate. Empathetic nurses experience compassion satisfaction when they're able to make a difference to others. You all are very aware about empathy. Jean Watson is a foundational, our nursing theorist in this program, and you're aware of that too. And she really talks about being empathetic. My assumption is you have met nurses in your time with us at Concordia who are not very empathetic. And you've met nurses who are empathetic. My hope for you is that you are always an empathetic nurse who cares about your patients to making a difference in their well-being. The caveat or the issue that can happen with people that are empathetic is that they can experience compassion fatigue. Now, sometimes people call compassion fatigue or being really empathetic the cost of caring. Because you care so much about other people, you forget to care about yourself. It's a personal cost to you. And what that can happen is that leads to the decrease in the quality of care you can give to others. All right? So this little conversation here, because nurses work in stressful situations and are exposed to others' suffering and death, we are at a higher risk for burnout compared to other professions. Burnout is everywhere. Met people in our walks of life who are very burned out. Doesn't matter if they're nurses or not, everywhere. But nurses are directly exposed. We are directly exposed to other people's suffering on a daily basis. And that can take a toll on us, especially if we are an empathetic nurse, which is what I really am hoping each of you is. All right. Let's first talk about compassion satisfaction. So what compassion satisfaction is somebody who is empathetic, who meets the other's needs and creates an environment of caring. Again, I'm hoping that is what all of you guys do. But the problem is compassion satisfaction can lead to compassion fatigue. We've already talked about that. When we sacrifice our well-being for others. If we don't catch it here, compassion fatigue can lead to burnout and secondary traumatic stress. And ideally, we don't let it get to that because that's when it directly impacts us and our well-being. So why is there such an issue in nursing right now, right? Right now, we're having all these things that are happening in nursing, which can lead to compassion fatigue, burnout, and secondary traumatic stress. Staffing shortages is a problem. Nurses can be concerned about contracting infectious diseases and illnesses. We're directly exposed and always exposed to other people's dying. Lots to do for us to do in 12 hours. And especially as a new grad, you've never really had to do all of this in 12 hours. You guys get a week to do care plans sometimes. Well, in the real world, you don't get a week to do care plans. So it's trying to learn how to do everything in 12 hours can be overwhelming. Sometimes nurses experience a lack of support and a lack of leadership, which can lead to compassion fatigue and burnout and secondary traumatic stress. They're exposed to workplace violence, and they're afraid of being sued and losing their license that they worked so hard to get. All of this can lead to compassion fatigue, burnout, and secondary traumatic stress. So what can we do about it? I think that what we can do about it, and just so you know, a lot of this is all based on research, okay? So be kind to ourselves, be gracious to ourselves. Understand that we are humans, hopefully doing the best that we can every day, and some days we're not that good at it. Give ourselves positive self-talk. Why did we go into the nursing in the first place? What is our why? And I believe that in your foundations class, that's talked about. What is your why? Don't forget what your why is, because you will get to a point to where you may experience compassion fatigue. It's very common in nursing. And the why can be the grounding force that brings us back to why we're here and why it matters. Eating right, going outside for small breaks, making sure we're exercising, taking care of ourselves, making sure ourselves are a priority, not just our patients. Yes, our patients when we're at work, but when we're not at work, ourselves need to be a priority. If you get overwhelmed at work and you can break away for a second, ask your charge nurse if you can step off the unit for 5 minutes, just to gather your thoughts and to take some deep breaths. Being mindful, evidence says that being mindful really helps prevent compassion fatigue. And what is mindfulness? Mindfulness is being fully present, being present in the now, not worrying about 6 months from now, being present today, not being reactive, but being taking it all in, being calm, thinking clearly. Not dwelling on the past or the future, that's all part of being mindful. Mindfulness is rooted very heavily in Buddhist and Hindu teachings. There's lots of research about mindfulness. When you have time, look into it. That will help when you are feeling overwhelmed. And if you get to the point to where you're getting burned out, mindfulness will help reground you. And creating a healthy work-life balance. That will help too. When you're at work, you give your all for your patients. But when you're home, you are home. And protect your time at home to protect your family and protect yourself.